And the mitral valve is the inflow valve into the main pumping chamber of the heart. And normally when a person's heart squeezes, the valve, it has two flaps. They come together and they prevent any backflow of blood. As people get older, those valves can leak. The two flaps don't come together properly. They're supported by these small string-like structures, and those structures can either break or elongate. And so that's what causes a leaky mitral valve. And it's bad to have a leaky mitral valve because you get short of breath and it makes your heart work a lot harder. The current treatment for a leaky mitral valve is pretty good and it's quite effective, but it is very invasive and it is open heart surgery. It requires a breastbone splitting incision. We put patients on the heart and lung machine, we stop the heart, we open it up and directly visualize the leaky mitral valve, and then we fix it. And the core way that we fix it is by replacing the broken or elongated cords with artificial sutures. They're made out of Gore-Tex or EPTFE, and that is a very effective and safe way of treating the mitral valve, but again, it's open heart surgery. We first started thinking about the idea of doing keyhole beating heart mitral valve repair back in around 2005, and we worked on this intensely in the laboratories here in the School of Medicine and advanced the device to a point where we felt it would be clinically useful. And we recognized that in order to move this into patients in a way that we could meaningfully treat a lot of patients, that we would have to commercialize the device. And so we were able to bring together a group of incredibly talented people and form a small startup company called Harpoon Medical. And that company was formed in 2013 and interestingly was supported by a number of our grateful School of Medicine patients, and we were able to develop the device within the company, and the company supported the initial clinical trials that we're now reporting that were done in Europe. I am a co-inventor. There were two other individuals that were working in the laboratory here at the School of Medicine with us, and so we all worked together as a team to develop the Harpoon device. In order to get a better idea of the Harpoon procedure and how the device works, let's take a look at a diagram that's going to be published in our paper. This figure up here demonstrates the incision. It's usually a 1 or 2 inch incision in between the ribs, and it allows us to access the front of the heart where the X is, and that's where we put the device through the heart, the wall of the heart while it's beating. And you can see in this patient, these are the two leaflets of the mitral valve. This is normal here. This one, I don't know if you can see, but there are broken cords, and so it's coming up above where it should be. And so what we do using ultrasound guidance is that the device is steered up to the leaflet that's flapping in the breeze, and once we're satisfied with the location, we have a specific target in mind, then we will deploy the device to anchor the suture in the leaflet. And this is how it works. You can see that the needle is extruded from the device through the leaflet, and the needle is withdrawn and it leaves a knot that looks like a double helix right there. And so that's the anchor. And then you withdraw the device out of the heart so that you would have a pair of artificial Gore-Tex cords coming out of the heart. You repeat that on average 3 to 5 times for a single patient, and then you tighten those cords as you watch on the ultrasound or echo machine, and you pull down on them until you get a perfect result where the two flaps come perfectly into alignment. And once you're satisfied with that, then you simply tie them off over a small felt square here, and that's the end of the operation. The study that we've just published in the Journal of American College of Cardiology demonstrates in a trial that we did in Europe at 6 centers with 30 different patients, we showed that we could do this procedure in half the time as conventional heart surgery. The amount of blood loss was minimal, and it was an extremely safe procedure. We had no patients that died related to the procedure. We had no strokes. We had to give only one patient a blood transfusion, which is far different than conventional open heart surgery, where almost half of people need a blood transfusion, and patients were in the hospital for a fairly brief period of time. So it really is a less invasive way of accomplishing essentially the same thing that we do with open heart surgery. We are anticipating approval for sale in Europe in the coming months. For the United States, the FDA is likely to require a fairly large prospective clinical trial, which will take patients and randomly assign them to either conventional mitral valve surgery or to Harpoon repair. So for that trial to enroll and complete and to have follow-up, I anticipate that it will be a number of years before this therapy will be available to American patients.